First of all, just to say how much I appreciate being here, and to be really clear, this wasn't an Alberta Health Services project, although it's working around partnering between healthcare providers and the Pride Society. And so really, I'm here as a member of the Pride Society. And I don't know how to do this. There. It was upside down. And so there, greetings. You can see Patty and her red calf, one of our 40 cows on our farm near Peace River. We farm 800 acres. I mention that just because I think that the perspective that I bring is a bit different from some of the more urban perspectives, and it's something that kind of fascinates me, that when we moved up to the north, in terms of how folks who live there feel supported or do not feel supported. And also, I identify as a queer bisexual man, and I don't think that we're very well represented in these sorts of conversations. So, yeah, that's why I mentioned that. I really want to acknowledge the Peace River Pride Society Board, who are the main body within which this work is done, but also Alberta Health Services healthcare providers from mental health promotion, nursing, psychology, and social work, because it really is this collaborative project with these allies from healthcare that are making this possible. And also provincially, because there's this amazing disconnect probably most places, but between what goes on provincially within Alberta Health Services and the diversity and inclusion group, where all this wonderful stuff we discovered that we were completely unaware of was going on, compared to what was actually happening in our local area. And so just to be clear, so I'm an occupational therapist and mental health therapist, but my role within this process has really been as a community member. And so how did this all start? It starts with conversations about healthcare. And so with it, I'm not a member of the board, but my wife is a member of the Peace River Pride Society board. And so I would go along because we have a long drive and it would be boring for me just to sit and wait. So I would go along, and I ended up consulting to the group at some point. But there were these conversations, and they were conversations that were particularly problematic because they were often about how people avoided healthcare. And they avoided it because they felt stigmatized when they attended. I just want to give recognition to my wife, Ruth, who is a mental health promotion facilitator, and she develops training for diversity and inclusion, and she's been very successful in our community in bringing people. I don't know if people know Chris Wells from the University of Alberta, now at Scott McEwen University, and Marnie Panis, who is with Diversity and Inclusion, a trans woman who's very well known. And when those folks came to Peace River to provide training, that did also really kind of give momentum and traction for the development of this project. So methods, so really not a very sophisticated methodology, really focusing on community development and a quality indicators framework. And one of the challenges really was to try to focus on very small changes that will eventually make up like the more important social and political transformations that we are talking about. So that's one thing we try to keep a lot of track of, is like any small changes, the little things that happen. One of the things that did occur, maybe I'll just move on, sorry. So this is the community development model that we used. And what we found helpful about this was this idea of combining the idea of empowerment or gaining power for individuals, and really all about finding kind of queer voices in a northern rural community. And recognizing that really is the fundamental purpose of a Pride Society, is to provide voice to folks who maybe aren't heard that often. And and I'm always amazed, actually, that Peace River has a pride parade, that their mayor marches in it. You know, I'll be quite frank, 15 years ago, like when I first arrived, and people would tell me they were going to have a parade, I was a bit like, oh, is that safe? You know, but it turns out it's always been like well attended and a very successful event. But also the nice thing about this model is it combines it also with the sort of skills that individuals within a community development model will be working through as they work through the process of engagement and participation. Because I'm an occupational therapist, I used a framework from the World Federation of Occupational Therapy to look at quality. It happened I was doing a graduate course and we had to design quality indicators, and so I was like, oh, hey, we could design quality indicators. So these are some of the areas you could focus on: structure, process, and outcome. And then dimensions, there's a whole list of dimensions. But really what we focused on was structure, quality perspective of structure. So we do that because as outsiders looking into the healthcare system, we don't really have access to the data to make kind of more complicated analysis. But we're very good people to look for visual evidence of inclusion. And one of the focuses we had was on whether healthcare providers had the foundational knowledge and skills that they required. Are the systems in place for the delivery of sensitive or specific healthcare services? People were always talking about the context in which they received healthcare, whether they felt supported or generally not, that sort of thing. And we really focused on accessibility, because that was one of the initial conversation that we had, was just basically that people didn't feel that warm handshake. They didn't feel safe to talk to their healthcare providers about sensitive issues. One thing I relate is speaking to a physician about PrEP, for example, and she said, "What's that?" And then, get on with it. And she said, "What's that?" And I said, I explained, and she said, "Oh, that wouldn't be good." And so, yeah, just really not feeling included. The willingness of the system to respond to the needs of individuals. And so our goal is to influence the system to improve emotional safety as well as the health care that is specific to the needs of individuals. And so we're hoping that this process will start with that welcoming posture, that warm handshake, and really trying to build that willingness to listen, reflect, and take action to improve the quality of health care. When you're designing quality indicators, they advise that they're specific, measurable, agreed upon, relevant, and timely. Agreed upon was probably one of the interesting ones. Like, you have a group of community members and healthcare providers trying to decide like what matters. And so that was interesting. In community development, you're always focusing on the setting, like, because it's local and you want to describe this situation. So there we are. We live in northern Alberta. We're 7,000 people in the town. I live outside the town. There's about 20,000 people who are served, so 27,000 people. But there's also First Nations and Métis settlements around us that also are served. Healthcare providers, the Provincial Health Service, also First Nations, Inuit Health, which often work in conflict with each other. There's a local health center. Addictions and mental health is delivered in a different building than the rest of health services. And there are 2 primary care clinics because they couldn't agree on a funding model, I think. And tertiary care is provided 2 to 5 hours drive distance or by video link. For an example, like once my son cut a tendon and we were sent into Edmonton, 5-hour drive. When we arrived, it was just to see the surgical resident to make an appointment. So there's some challenges in getting tertiary care a long way away because they're idiots. So strengths and challenges. One of the things so when we began this process, we had all these questions and ideas about quality indicators, and we were actually, even though we worked, those of us who were acting as allies, the healthcare provider allies, even though we worked in Alberta Health Services, we were actually unaware of provincial initiatives from Marnie Panis's office. And so so it was clear that those were not being enacted locally. But we did have this evidence that locally the services were not what they should have been. We were particularly concerned about this knowledge, like I mentioned about PrEP, for example. Just that people don't ask questions about gender or sexual health. There's obviously stigma. I don't know if all rural communities are as religious as Peace River. There are a lot of churches there, and a lot of healthcare providers actually come because of unusual churches that are there. So yes, accessibility and appropriateness of addictions and mental health services was an issue that certainly people were talking to me about. We were lucky because in terms of, can I go back? Oh no, okay, it's okay. I've lost my place, I apologize. So indicator development. One of the things that we were lucky was because provincially, actually, there were some indicators that we were unaware of. So we adopted them, but we needed a rating system for it. And people might know about how it's usually counts or it's proportions. These indicators are usually done. But we found actually a better indicator system I'm going to tell about in a moment. And then we developed 4 specific indicators. And so the rating system is this system that is actually designed for municipalities. But it's kind of a great way of thinking about inclusion and diversity, and particularly this one was focused on the LGBTQ2S inclusion. And so it goes from invisible to a culture of inclusion. And it was the sort of thing that we could look at as outsiders, like the community members could look at the healthcare system and make judgments using this sort of a tool. So the generic indicators, these were the ones that Alberta Health Services gave us. So our AHS, a safe place, the first 2 are about posters. But interestingly, we gave them an awareness rating. So the organization was obviously aware because they made the posters, but they weren't available. They weren't actually up. Then do physical spaces reflect sexual and gender diversity? We thought that was invisible. There was no evidence of that. Does your service provider provide inclusive care? We rated things generally, like as if we were kind of averaging it, because we did have like some unusual things, like people who had, on one floor of addictions and mental health, people who do have little flags in their windows. But even those of us who worked in mental health weren't 100% sure whether those people were competent to provide service. So we gave those both invisible. Do patient teaching materials, these are still the generic indicators. Do materials reflect sexual and gender diversity? We couldn't really see that. Generally, they were kind of cis-normative images. Are there accessible all-gender washrooms? Yes, all washrooms were, except for staff. Staff had segregated washrooms. So we call that intentional inclusion, but we're not 100% sure why they made inclusive washrooms. We suspect it had nothing to do with any intention of being inclusive. Are LGBTQ resources available? We gave this one a much higher rating, strategic inclusion, and that's because provincially there's a lot of educational materials, again, things we actually weren't even aware of, that came to our attention as we were going through this process, but that could be helpful as we think about how to move forward on this project. Then the specific indicators. So there were 4 issues that people felt strongly about, and so the first one is just a more general one. Are healthcare providers, including primary care physicians, aware of protocols for transgender health and confident in providing transgender health care? Our group has 2 transitioning folks participating in it, and so their stories informed this, and it was quite clear that the physicians didn't feel prepared to be helpful in that northern community, but they were pleased that the physicians attempted to. So they would go and find out more information, and they would work with the patient to get more information. Are healthcare providers aware of PrEP, and do at-risk individuals have ease of access to PrEP? A fairly resounding no. Our sexual health services that address the needs of LGBTQ2S community members, including easily accessible testing for STIs available and promoted. We said awareness because the primary care clinic does provide testing, but we heard stories about people being told they didn't need testing. This were gay men who were sexually active. Some sort of judgment about particularly whether they needed an HIV test. Our mental health services, including anti-stigma interventions available. We, in some ways, this was probably the issue that kind of drove the whole process, because most of us healthcare providers who are interested in this actually come from addictions and mental health. And we had, certainly when I arrived 15 years ago in Peace River, I experienced a great deal of stigma from healthcare providers as a bi guy. And so, yes, we found that was invisible. So we need to confirm the indicators and ratings via a consensus process. So this is really kind of an informal Delphi working with the community. Conversations with local healthcare providers, a bit nervous about that, but really just feeding back now to folks who didn't invite us in. So we'll see where we get to. Addictions and mental health seems to be willing to meet with us. Physicians aren't talking to us. There's the people at the hospital seem quite open. Imagining a developmental partnership process, how they'll go forward, and the possible establishment of more formal local area working group within AHS. So we had established this working group on our own, and then we discovered that provincially they were encouraging the development through the Alberta Health Services Diversity and Inclusion Council, and they call them workforce resource groups. And this was, I was actually invited as a result of participating in this project to join the provincial one, and also that we would be asked to develop local ones. So there was lots of provincial stuff, but not a lot local. And then there were the references.